morning to everyone, and would like to say the good morning to the people working in the lab, and thank you so much for setting the stations for everybody. And Jessica and myself, we will kick off the wet lab exercise, and I also would like to introduce Mr. Rabia Dandachi, who will scrap today. And Rabia is a former US Navy scrap nurse and working my team for ages, teaching the OR personnel all around the world. So if you have any questions, please refer to Rabia. And 17 years in Medtronic or 19. Something, 19 in Medtronic, okay. So thank you so much for coming to us. So, you know, it's been last, I don't know, 7 years or 8 years when we started to talk about the ergonomics of endonasal sinus and skull-based procedures, and all things matters. And as Thibaut mentioned this morning, the position of the equipment and having the people working with you, whether it's the scrubbing team, whether it's anesthesiologists, is extremely, extremely important. So there are some things which are under our control and others which are not under our control. But the way you hold the endoscope, it's totally up to you. And after all this, I don't know, 25 or 27 years, I've been working in this profession. I was trained all kinds of different ways how to hold the scope. Many things has changed, and some of them were driven by the fact that we work with different specialties like neurosurgeons or oculoplastic surgeons. So we changed the arrangement of the cables and cameras, etc., to accommodate four-handed surgery. So this is the thing number one. Number two, to refer to zeroism. I love this saying, Tiva, by the way. Some people use the zero scopes, and I'm one of these. And after the years, I am more 0 and 70 degrees scopes. But I know that some people use 30 degrees also because they don't have 0 degrees scopes in their practice. So you have to be prepared. So what we have right now, it's a 0 degree scope with the cable and with the camera. So what we recommend, at least in my practice, is when you have the endoscope, there are two things you need to remember. First thing is to avoid any uncomfortable position for your wrist. So it has to be aligned with the axis of your arm. And the second thing, I personally, for the 0 degree scope, rotate the cable, allowing the cable to run on the top of the head, just to minimize number of stuff that is here. Jessica, you do the same?
I turn mine sideways to the...
Like that? Okay, so that's, you see, but the main thing is just, if you can avoid holding the cable like that, because there's so much going on here, so whether this way or that way, it's up to you. Second thing, just follow the law of physics, because the most important thing is to keep the balance. And if you use the free two axes, the axis of the endoscope and the camera and the cable, then it's very easy to maneuver, because actually you get the dynamics of the endoscopic image by flexibly moving the endoscope and the camera. Okay? Just any comment? Yeah. Okay, so this is the way I hold the scope, or whether like Jessica like that, it's more or less the same principle. It's totally up to you. The one thing is important, just do the same way to create the automatic habits, and you don't even think about it. Now, so once you have, and you see, I'm trying to hold this 90 degree position of my arm and the endoscopes, and it gives me really the minimum effort I need to keep the camera stable, because the stability is the most important thing. Now, the next thing is how you can make the environment supporting you. And one of the ways is to use the nostrils as your supporting system, your gateway to the nasal cavity. So use the top of the nostril to stabilize the endoscope. And then it's really, really easy to manipulate the endoscope. The principle number 4, you need to see well, and you need to be not too distant, not too close to the target of your action, and always do your best. If you look at the round view of the endoscope, always focus on having the target in the center of your attention. So for example, if I would like to address this middle turbinate, I need to look at the turbinate in the middle of my view. Not like that, not like that, and not like that, because I can't see very well. So not too close, because I can't see well and I am struggling with the refraction of the light, and not too far. Okay, so this is another principle. And then remember that with the 0-degree scope, the way you see is more like a panoramic like that. When you switch into the angle scopes, you see more in this manner, and depending whether you have a 30, 45 or 70 degrees, the angulation is bigger or smaller. And then when you take the angle scope, you can take the benefit, yes? Because, let's change the endoscope. Because it doesn't matter. And we change now to the angle scope, and I will show you how you can take the benefits of looking at the things in a different way. So I had a 0 scope, and now I will change into the 30 degree. Okay. Always remember about white balance. Okay, so this is in the angle scope. That's a different story with the cable, because if I change the angulation, the position of the endoscope, I actually change what I see. So right now, I look. It's the primary original view, yeah, and look what happens when I insert the endoscope. So I'm looking, I see more above, yeah? But if I would like to look at the lateral side of the nasal cavity, I'm on the left side, obviously, look what happens here. I'm looking more laterally, and I'm looking at what? Natural ostium. Towards the natural ostium of the maxillary sinus. However, this is actually the fontanelle, because you can't see normally in the nasal cavity the natural ostium, but we will come back to this. So this is a great specimen to show you one of the commonest mistakes done when you do the maxillary sinus, and it's still happening all the time, that you never ever see the natural ostium of the maxillary sinus. So when you have these 2 layers of the mucosa seen and shining through, this is the posterior fontanelle. Okay, so this is the difference with the scopes. Now, coming back to the 0-degree scope and continue with the automation. So as there was this morning discussion about the close checklist, we don't have to be obsessed with anything, but it's important to have a plan and come back with the structured journey. Always do the same. And another additional benefit of close is that automatically focuses you on the relevant big anatomical landmarks and big anatomical structures that you want to avoid. Okay, so the next thing I would like to show you is the endoscopic examination, or maybe before we have the specimen covered. It's extremely important also the way you position the head of your patients. It's not only about the table setup, but normally what we're trying to do is kind of extending the head so the spine is as straight as possible, and slightly rotate the head towards you. It simply prevents you from leaning above the operating table. So this is what we've already done. and we are ready to do the endoscopic examination. So there are a number of ways you can do it. The one important is to do everything is needed and not miss important structures. So we like to think about endoscopic examination as three runs, 3 steps. Just, do you have anything to add? Just stop me anyway. So the one way to do it on the left side is to make the first run, which is basically within the main corridor of the nasal cavity. I usually go along the floor because you have much of the space, and I would like to get to the posterior part of my area, territory of the inspection, which is the posterior choana and nasopharynx. We have some clot here, and inspect the eustachian tube orifice. And we have the anterior and posterior cushion, and I look into the Rosenmüller fossa. And then pulling back, I can eventually look into the sphenoid sinus natural ostium, and pulling back, I inspect the inferior turbinate. I check the posterior pole, whether it's hypertrophic, until the anterior one. And if we plan to do the prelacrimal approach, it's very important to inspect this area and identify the piriform aperture. And then eventually you can inspect also the area underneath the inferior turbinate, where there is a drainage pathway of the, and you can see very nicely Hasner valve, yes, underneath. Okay, now if I go with the second step, I can inspect the roof of the nasal cavity and check the septum, the positions, potential deviations, the roof, if there are any polyp formation within the nasal cavity. So this is the second run. And in between, to check the middle turbinate, the superior turbinate, and eventually the supreme, if it's present. And these things you know by the inspecting the, and there is a supreme here, at the CT scan. Okay? And the last run is into the middle meatus. So this is my middle turbinate and its attachment to the lateral nasal wall. And then the second thing I need to understand is the uncinate process, which is my first lamella, according to the embryology we discussed. The second is the bulla ethmoidalis. There's a suprabullar space. This is the basal lamella. And then we can see very nicely the posterior fontanelle, which in this case is covered by the mucosa. Okay? Now, I've prepared, do you have any questions for this part before I move forward? Okay. So another point for the demonstration today is endoscopic septoplasty, which I believe that the endoscopes brought a lot of help for septoplasty, especially in the posterior segment. So I personally always start with the speculum for making the hemitransfixion incision. So in this particular specimen, you see I moved the columella already because I made a transfixion incision. In this specimen on the left side, because the cartilage was luxated into the left side, outside of the columella, as you see here. And it's always simply easier to make the hemitransfixion incision. So in this particular case, it was a classic, as it was called by Eugene Tardy and Dean Toriumi, too much cartilage in the envelope. So we had a very tiny slide from the maxillary crest on the left side and deviate it. So this is the one thing. Second thing, when you do the septoplasty, the most important thing is to make the flap in the current place, so it's subperichondrial and subperiosteal. So this is what I do. So sometimes when it's not that easy, or in the revision cases, I use the knife to make some scrap on the surface of the cartilage just to get the right plane. And then you go further deeper until you identify the connection between the septum and the bony parts. And this is something you actually nicely can sense with the knife or the cuttle elevator or whatever you have in your hands. And elevate the flap as much as you want, depending what kind of work you need to do. So in this particular case, I prepared the upper tunnel, anterior and the posterior, and it's usually easier to elevate the flap on the bony part, which is quite thin here. And in case you need to do also the inferior tunnels, which almost always you have to do, sometimes it's easier to start posteriorly and go anteriorly to elevate the flap. And the endoscope gives you very good visualization and also allows you to make a super meticulous elevation without damaging the mucosa. So as you see here, this is the bone. There's a little bit of the spur, and I went down here onto the floor of the nasal cavity and made the elevation, and can come anteriorly then to elevate the flap, and inferior also on the left side as much as I need. If you have the big spur of the wing on the premaxillary is really deviated, that's quite helpful. So here you see the maxillary crest. This is the cartilage. And if you want to chisel this part, depending on the situation, it's important to remember that this is a wing. So you have to dissect, you have to change the position of the instrument in order to dissect the flap. Otherwise, this is one of the commonest places you may damage the flap, which is not a big thing as if you take care of this properly. Okay, and then this is the tunnel, and then depending what you need to do, you need to detach the bony part from the cartilage. You make the posterior cut, the inferior cut, and just address the deviation according to the situation. So these are the principles. Yeah. So it was just the principle, and then I come quickly to the maxillary sinus. I need double end probe. Okay. So the first thing, very important to do, is identify the uncinate process, the posterior edge, because you may have a different situation. You may have a polyp, so you may have a paradoxically curved. So maybe a number of different situations. So this is the vertical part, and then turns down into the horizontal part. So you can use the whatever instrument. Over the years, I changed my technique, and I show you now the way I do it. So once I identify the transition between the horizontal and the vertical part, I switch into the backbiter. And always remember, when you insert any instruments, you open the instrument, position the instrument, don't rush until you are sure that you're in the right position, and then you make a bite, and depending on the situation, a little bit the upper, okay, and the probe. So I already see in this situation lateral ostium. I can see the fontanelle, and this is what Jess just said, that if you have this kind of situation, you need to combine the natural ostium with the posterior fontanelle, otherwise you will end up with the circulation, okay? So this is, and then the size of the opening will be discussed later. So this is the first step. Can I have a cutting? Thank you. So depending on the situation, what I'm doing now is so-called creating a bit of the mucosa soup. And now there are a number of ways I can remove the uncinate. So the most important is to create the conditions for primary intention healing. So to have the maxillary sinus mucosa and nasal cavity mucosa meeting with each other. And now, depending how you want to do, you can use the side biter if you like, or you can simply grab the microdebrider and just remove it. So I don't know if you have a side biter. If not, just to show you how it works, simply. And what I'm doing now is just creating the pieces of the bones. As you see, making a number of bites. And if I switch now into the microdebrider, I will just remove the... Again, and the last thing about the microdebrider, I have a straight shot now. As you see, I always position the open jaw. There are a number of, some people say you should insert the microdebrider with the closed jaw, or with some people with the open. As you see, I'm now running the edge, removing this mucosa soup. And now I'm absolutely safe because it's a loose tissue and it accelerates my work. And it's trimming very nicely. A little bit rushing. So this is just the principle, okay? I will stop now as Jessica will continue with the mega-antrostomy. And now the last part is the removing of the, I can take this one, yeah. The vertical part of the uncinate process. So again, I'm using the upcutting instrument. And as you see here, I position the way I want the instrument to cut. If I have any doubt, and I'm parallel to the lateral nasal wall to avoid the damage of potentially the orbit, you need to inspect the anatomy. If you have any doubts, you can also use the probe to make a laxation of the tissues. Sometimes I take this tissue for the biopsy as well. And again, the same principles here. You see, I position the instruments, make a bite, and it's important to remove the uncinate completely. And as you know, the uncinate up there forms the lateral wall of the Agnieszka cell. And now I can also switch into the microdebrider. And again, you see the jaw. Make microdebrider the extension of your hand, yes? So you see, I'm just removing it, and it's very clear. You already have the Agnieszka cell open, quite a big one. And removing the remnants of the uncinate. Any questions?
Are there any questions? Yeah. So I just think one thing I would like to add, if you look into the antrostomy, you still have a small piece of, let's say, connective tissue. So you really, with your backbiter, you really have to remove it, otherwise you will have this recirculation. So there you see, if you look laterally, so your natural osteum is always more anteriorly and more superiorly than you think. So you really have to connect those two, like that. Voila.
Yeah. Great. Okay, I'm leaving here to let Jess work. And the last thing, Yeah. So there's the again, as I said, if you want to perform the intact bulla technique for opening the frontal sinus, this bar you may leave in order to get the better understanding, and then you go up there and analyze whether you have a lateral or medial drainage towards the ansonate process. And we are already inside the maxillary sinus. We have the first anatomical landmark identified, which is the roof of the maxillary.
First, Thibaut asked if I would comment on the removal of the uncinate through a retrograde or anterograde approach. And so I know some folks open the uncinate and start anterograde and then remove this. You can run into issues. It can be smashed up against the orbital wall. You can injure things. Go and find it, retrograde, and then remove it this way, okay? Don't be punching through it anymore. We don't have to do that, so do it the safe way. The thing we're going to cover is the mega-antrostomy. Now, I'm going to caveat, I don't do this. I do a modified meiomaxillectomy, but I'm showing you this for the sake of the educational component, much to the chagrin of Professor Harvey. Okay, so first step is I get a pair of sharp scissors, and in a patient who's got a blood supply, I will actually take a hemostat and I'll clamp it across the inferior turbinate, because we take that in the modified meiomaxillectomy as well. I take more of the inferior turbinate for a modified. This is a different procedure. So you take a curved scissor and I cut the inferior turbinate to its attachment at the medial wall. And then you can push this posteriorly, and then you can take this at the back. I'll take a true cut, a straight true cut. And you can separate it here posteriorly. You will have to control the inferior turbinate artery back here with some kind of cautery, bipolar, monopolar. Okay, that can be used as a free graft if you ever needed one. And then I also went ahead, in this original description of this, when they raise any flap with a mega-antrostomy, it is 2 90-degree incisions. One is at the posterior limit of the sinus, so I've already made that incision, and one is kind of at this anterior limit. And the reason I did this is on purpose. I don't do 90-degree incisions, and I have a lot of reasons why I don't think those are the right thing to do, but this is how this was described. So I'm showing it to you, and then I'm going to tell you that I never do it, and I would suggest maybe you don't do it either. All right, so the flap can be elevated, sit up against the septum. I use a caudal elevator to elevate this. In patients who have even thinner skin, you don't want to get tears and holes in this. And then you can come right over here to the maxillary wall. And with a J-curette or a caudal, you can just enter through this portion of the wall, and I mean, you can take this all the way up. And then I'll take that true cut. Thank you. And take all of this bone. All the way back here. Can I see your back better? You also want to take all of the superior stuff. I did that with a Kerrison up or a backbiter. Okay, thank you. And then also down here on the floor. Okay. In that first description of the mega-antrostomy, there was not a ton of drilling of this. So like this would be the final product, okay? And you would just lay this flap back over this bone. And then my issues with this, one of the reasons why I don't use this approach is that you've got some area that could still be open further anterior, you've got exposed bone here, or you're going to expose bone back here. But if you can drill all of this away back to that kind of pyramidal section where you start to get nerve and artery, which will probably take you back there this way, and this little segment of bone here, another little pyramidal shape, then you'll actually have all of your bone covered, and you can even resurface the floor of the sinus. All right, take your microdebrider. And then we're gonna, when we do the modified medial maxillectomy, we're gonna actually drill, and I don't know who's doing that dissection, but that's the procedure that I use.
While Jess is tidying up, it should be worth noting that when we do a modified medial maxillectomy, it's not about making a bigger hole. That's not what it's about. It's not like saying the antrostomy is a hole and we're going to make a bigger hole. The modified medial maxillectomy is all about making sure you can get into and access the maxillary sinus and then leave behind a cavity that doesn't collect mucus anywhere. You don't want to leave behind a cavity where there's a giant inferior pit, prelacrimal recess, places where mucus and crusting can collect. You know, so if you said to me, that's where, I don't know how often you perform a mega-antrostomy. It's sort of, in my mind, a bit of an older procedure because it was at a time when sort of maybe making a bigger hole was thought to be better. That's not really what we're trying to achieve.
Yeah, I never do this. But like this, without taking all of this bone down, without modifying the way that the flap is elevated where the anterior cut comes all the way towards the front of the nose. But for the sake of 360 education, we'll cover it.
Excuse me?
Yes.
Could you please point out where the nasal lacrimal duct is now located in terms of where you are?
So if you go under this inferior turbinate, you can still see Hassner's valve is.
Anterior.
Yeah, it's still anterior to me.
Yeah, you can actually see it here. Let me
Yeah. Point.
let me pop this in.
Yeah. Thank you. Yeah. Nice.
That little thing there is Hassner's valve. Can you see that? That's
Yeah.
the nasolacrimal duct coming in through this thing here.
And we're still miles away, really,
Yeah.
in the nose, right? Kilometers, sorry. Many kilometers away. Okay.